Welcome to Beyond Sound, the podcast exploring the future of hearing restoration, cochlear implantation, and the science transforming how people reconnect with sound. In this episode, we dive into one of cochlear implantation's most debated questions. Does electrode design significantly influence functional outcomes in single-sided deafness, or is it primarily a surgical choice? From neuroplasticity and long-duration deafness to counseling strategies, rehabilitation, cognition, aging, and evolving surgical philosophies, this conversation goes far beyond the implant itself. Brought to you by the Hearing Group, an independent international network of leading hearing implant centers, surgeons, audiologists, and researchers dedicated to advancing hearing restoration through collaboration, education, and innovation. Featuring renowned hearing experts from around the world, we would like to welcome our moderator, Professor Gunesh Rajan, and our panel, which will consist of Professor Rudolf Hagen from Germany, Professor Dayse Tavora-Vieira from Australia, Professor Sima Sugarova from Russia, Professor Meg Dillon from the United States. Now, welcome. This is Beyond Sound.
Topic to discuss: the electrode conundrum. Does electrode selection significantly impact functional binaural outcomes in SSD, or is it primarily a surgical choice? So, difficult question. But let me first start with our hearing counseling tool, because we invested a lot of time to set up this hearing counseling tool. And as you can see here, there are 4 different topics. And we started with the single-sided deafness solutions, because in our opinion, this was quite easy to create this counseling tool. And fortunately, the number of users is growing instantly, according to Peter, he told me that. But let me ask to all of you, does everybody know about this tool, and has everybody used this tool? Hands up. Yeah, at least a few. This is nice, Peter, to hear. So there are the 4 pillars in counseling: no treatment, cross-hearing aids, bone conduction solution, and cochlear implant. And what is also important, we found a consensus on a diagnosis and pre-treatment before CI in single-sided deafness. And if you keep to this consensus, this takes a lot of time, because you start with the cross-hearing aids, you start with bone conduction solution, before you then finally do your cochlear implant. And of course, cochlear implant is the only solution which is restoring the hearing. And we also listed the benefits, the different benefits from audiological aspects as well, medical aspects and patient-reported aspects in this counseling tool, and also the drawbacks in all these aspects already told. And there is a number of references which makes it easier for you to refer to these decisive papers. So we looked into our own data, especially in children, usefulness of cochlear implantation in children with single-sided deafness. And fortunately, we found out that cochlear implantation benefits speech recognition in noise and sound localization ability in children with SSD at different ages. And all implanted children are full-time users regardless of age and duration of deafness before implantation. But coming back to the question about the electrode, in our group, all children were implanted with long electrodes, that means 28, or the flex standard electrode. But this is our data. And now I went to PubMed search. Is there any hints on length of electrode in single-sided deafness? So I entered single-sided deafness, cochlear implant, electroacoustical stimulation. No one hit. Single-sided deafness, cochlear implant, electrode length. No one hit. And I reduced to single-sided deafness, cochlear implant, electrode, and finally ended up in 30 articles in reviews, which came to the same result. CI is better than other procedures. Of course, this is a clear result we all have. But there was no one discussion on the electrode. So let's conclude this question. Due to the limited numbers of patients per SSD study, a comparison between electrodes was not in the focus yet. That is not in the focus yet. And looking to our hearing philosophy of complete coverage is highly recommended in single-sided deafness, especially if there is a complete deafness. And third, the recent advances in autoplan should be used for an appropriate electrode selection, because we have now fantastic possibilities to find out the best electrode, as well as to use autoplan also for an optimized ABF in single-sided deafness. Of course, there are further questions for clinical research, for example, different sizes of Cochlear, and let's continue discussing.
Okay. Well, my question was, the question that was given was, what is your 3 key resources that we use? And I find it quite difficult to put it together, so put 3 here. I hope that we are in agreement. So my number 1 is education. I think that this morning has been brought many times already in terms of the education, that this knowledge that we need to have ourselves and also pass on to the patient to help them to make that decision. So it's a knowledge that is not based only on clinical experience, but based on evidence. I think that is very important that the patient knows the research that we are doing, what the results that we are achieving, to help them to actually set the goals, make that decision appropriately. We are never going to be able to get 100% patients, the right patients, but I think that it has helped in our center to get the right patient and the right outcome, particularly when we are talking about single-sided deafness. So I put it there. For me, knowledge is the first resource. So this education, this very high-level education to the patient, helping them to set their expectation clearly. I just put on the screen one thing that we adapted in our center when we are helping patients to make the decision, to make an informed decision. So these are all the topics that actually we cover with each patient, and actually showing them what are the evidences out there to support their decision. So number 2 is related to cognition and oral rehabilitation plan, right? I think that for this, what I'm trying to say is, what is the patient bringing? What is their cognition ability? How long have they been deaf? In terms of what is the neuroplasticity possible with this population? Depends on the duration of deafness, depending on the etiology. What are actually they are bringing to the table that we are going to be able to work with? And of course, to plan the rehab, right? Because the rehab has to be specific. It's specific for the patient, but also take into account how they can work, their age, what is the material that we're going to use, what is their reality, as Meg said before. Do we need to prepare something that is to do at home? Is that a face-to-face? Is that a group therapy? Is that a virtual clinic? So I think that we need to take all of that. So that's my toolkit number 2. So it's training the brain to hear again, right? So that is probably the bottom line. The toolkit number 3 for us is and has been discussed several times already, is this psychosocial support. It's not only the patient, it's not just the ear that we are working on, but their social environment as well. So, and this again has to be tailored for the patient, right? Is that a one-on-one? Is that a small group? Is that a full support in terms of network, peer help? So all of this put it together. So, and this is what is going to happen, these patients in the long term. I think that we have been seeing more and more. I'm kind of like battling between bilateral deafness, single-side deafness. I think that everything is here is for both, but for the single-side deafness, it's very important that they don't become a non-user. So that is the summary: education, rehabilitation, and support.
Thank you. So these are three important areas. I think that's been reflected, quite a few times, as you said. Do you actually have toolkits for this, or is that something you've conjured up, created yourself?
Sorry, Ganesh, what is the question again? I was a little bit distracted.
You're talking about toolkits, which is great. So do you have tools, or what are the tools you have for them? Or did you have to create them?
We created them as a team, so this is something that we have been working on. We have speech pathology and psychology in our group. And actually, we have created really toolkits that's actually personalized. And even our rehab auditory training is actually personalized for the patient. And we work with them before the decision making. And it's part of the decision making. Are you willing to, and you have to sign this piece of paper saying that I'm willing, I understand the process, I have chosen this implant because of this, and I'm willing to put the time and the effort into the rehab.
Yeah. Sima, counseling as surgeons, counseling patients, what do you do differently as a surgeon? If it's a patient with bilateral deafness who comes in for a cochlear implant and a patient for single-sided deafness, how do you approach it? What's different?
So the main thing that patient is waiting for normal hearing like the normal side. And I think that's the main goal is to describe that it will be not like that, and especially the first months. And this is crucial because especially adults, they're getting really depressed. It's a big psychological problem because I thought it will be like it was before, for example. And the main thing is to explain in details about that it will be different, but wait a little bit, and you will like it. Half a year, I don't know, in a year, it depends on the etiology and the duration of the deafness, of course.
Yeah, thank you. Rudolf, how do you approach patients? How do you counsel them from the surgical perspective as a surgeon? Yeah.
So she told us all the correct things. That is really important, very important to keep the expectations low, because they have never the same hearing like in the other side. But if you have a good counseling, then the patient afterwards, if he accepts that it starts a little strange and it takes more and more time to adapt, then the acceptance is much higher. But this is the crucial point. Keep the expectations for the results shortly after CI as low as possible.
Okay, good.
So first of all, I'd like to thank Professor Simon for this wonderful conference and this amazing place. So my topic will be today the etiology, and it was a lot of presentation about etiology. So I will try to summarize the information. So which specific etiologies require fundamentally more intensive counseling and why? So why etiology matters? So first of all, it's expected rehabilitation outcomes and potential medical and technical risks, and the psychological and social dynamics we should keep in mind also. So let's look at these points in more detail. So what about expected rehabilitation outcomes? They depend on neuroplasticity, of course, and the integrity of the auditory nerve and central pathways varies greatly of etiology. So, for example, if we have the case for example, GJB2 of the cochlear nerve deficiency or post-meningitis case, their outcomes will be different. So, and of course, the parents in progress, so a child with, for example, stable Cognition 26 deafness will follow a different learning curve compared, for example, with a CMV patient. So we need to take into consideration the potential medical risks. It's, of course, the surgical consideration. There's etiologies like cochlear otosclerosis and malformation we should discuss with the patients, like Gunesh, difficult electrode insertion, and also comorbidities. So what about the psychological? So the patient family narrative, the story behind the deafness. So sudden, for example, vs progressive, the acquired deafness, it profoundly affects the psychological state, and we should talk about this with our patients. And the truly informed consent is impossible without understanding the etiologically specific prognosis. So understanding the etiology allows us to build a long-term realistic rehabilitation pathway, preventing disappointment and crisis. So, I'm sorry, I was preparing like the etiology, so it's congenital. I will pass this. And if we're talking about postlingual deafness, the common etiology will be idiopathic sudden sensorineural hearing loss, viral infection, for example, COVID, ototoxicity, and trauma. So, and why intensive counseling is critical. So the psychological trauma, we should don't forget about that. So loss of the connection to the world leads to anxiety, depression, and social isolation. It will decrease the motivation for rehabilitation process of our patients. And also very important is unrealistic expectations. So the hope for return to normal, lack of understanding that the brain must relearn to hear with cochlear implant. So intensive counseling is not about more information. It's about managing expectations, setting realistic goals, empathy, and psychological support, and building a long partnership with the patients and with his family or her family. And our role is not to be just surgeons, but also partners in this complex journey. Thank you.
Thank you, Sima. So I think you've shown rightly how etiology has an impact, the different dimensions. And so I've brought up the slide. This is sort of the query we had in the audience. As you can see, I brought up a few diagnoses where we consider single-sided deafness CI, and on top it looks like counseling for single-sided deafness after vestibular schwannoma surgery seems to be the most challenging entity. Do you concur with that, or do you have is something else more challenging in your everyday life? I mean, this is for us surgeons, like Rudolf as a surgeon, Sima, and but Meg and Dayse and Lee again as a surgeon. Do you have different perceptions, or does it reflect what you see here? What your challenges are in counseling these patients with these pathologies? Rudolf, please.
Of course, in vestibular schwannoma after surgery, if there's a deafness, it's really difficult to decide. And it's only possible if you are involved in that type of surgery, if you know if, for example, the cochlear nerve is preserved. And if you have no information on this, then it's really difficult to counsel the patient in a reasonable way. So I can understand why this is at the front of the list here.
Sima?
I think we have some quite the same percentage of the etiology. But the problem is that in Russia, the single-sided deafness is not paid by the government.
The reimbursement challenge.
Yes, and that's why I think we have not so much cases to have a real statistic.
Yeah, I think that probably we would agree, particularly, and if we go to the second one, the congenital, if we think about if it is children, if it is adults, so we add another complexity to the picture there. So, I would agree with what the audience has voted there.
If I could just build on that point, I think what's really interesting right now are adults that have lost hearing later in life, but it's been 40 years. And I think we're all still a little bit nervous, but we've seen a lot of success in that patient population. So they're a little bit different, and it's interesting to counsel that group because it seems very unknown of what that outcome will be. But if we lean back on our data from patients with bilateral severe profound hearing loss, we know 40 years of deafness, the outcome is not going to be as great. But for the single-sided deafness case, it makes the preoperative counseling a little different.
So that's in the early, the late 2000s or early 2000s, the age of onset is the question. In these patients, they come in several decades. I remember in Perth we did a trial, Dayse, where we looked at these long-term deafness duration, and you're right, they get there. They probably take a bit longer, but they get there. So has your assessment and counseling changed specifically in these patients when they come in? They say, I've lost my hearing when I was in primary school or something like that, right?
No, primary school maybe not, but somebody that lost their hearing in their 30s or 40s and they're now in their 60s or 70s, that's a different conversation. And when we designed our clinical trial, we said 10 years duration of deafness because that's what we had always known, is that 10-year mark. Yeah. And then the FDA reviewed our data, and that's unfortunately the criteria, or one of the criteria that stuck, is this 10 years. And now we've seen patients with longer durations of single-side deafness that are doing very well with their cochlear implant. And so now we're needing to show that data to make more changes. Okay, so I was told to keep it short, which got one slide, so that's good, hopefully. Okay, so in the United States, right now, cochlear implantation is not an approved indication for adults that are 65 years of age or up that are covered by Medicare. And so there are currently some movements underway to try to convince Medicare that this is important for this patient population. And we have two patient populations that we have reviewed and published on, two separate groups, which is important to consider. But in that, the major finding was that, yes, the outcomes may not be the same as they are for younger adults. However, these individuals experience a significant benefit relative to how they were doing preoperatively or in an unaided condition. And so it's really important to, instead of just saying, well, they're not as good as a 20-year-old, well, they are also experiencing a benefit from cochlear implant use. And so these are data that we are using to try to convince Medicare to change indications in our country. And this is a conversation that we have with our patients is, you can look at these publications. Many of them come in very well informed. And you can see these changes in performance that are happening. But we really need to think about what your abilities are, what your concerns are, and the potential benefit that you could get from this device. The other thing that has changed recently in our practice is all adult cochlear implant recipients, and children as well, but this talk is on older adults, are referred for oral rehabilitation, and they have two options that can either be in person or virtual. And our older adults do thrive with that in-person activity more so than the virtual. We have a mini mental state examination that is completed preoperatively for all of our patients, and that facilitates a discussion of when we have poor cognition, of how to involve families and support networks to best support these patients and their outcomes postoperatively. And then the HearCare app has been useful, particularly for those that are in an assisted living condition or cannot travel easily to the clinic and or provide appropriate feedback about how they're doing with their cochlear implant or how their cochlear implant sounds, because you can make some assessments of the internal and external function from that. So these are the major things that we're thinking about for counseling for older adults with single-side deafness.
You mentioned, back to this slide, you mentioned the setup you're having now with the HearCare app and etc. So I was just wondering, with what specifically in the elderly patients you find are different when dealing with younger patients?
So these apps have only recently become available in the U.S., but particularly for our older adults, it's helpful when we cannot get feedback from them. So if we need to measure something with the internal, see what's happening with the external, see what functions or listening situations that they're in. Are they just sitting at home in a very quiet environment? Are they in a noisier environment? That helps to facilitate some of the discussions and counseling of what realistically they should be doing with their device.
Yeah. And are there do you also look into the whole social side? they, where they're embedded in, what the family is like, etc. Is that an important factor? Or?
So those are conversations that are happening preoperatively. So, who's coming with them to the appointment? How long did it take them to get there? What's reasonable to bring them back? Are they able to drive on their own? How far away from the clinic are they? What sort of resources do they have at home? All of those are conversations that are happening. Now, for somebody who is, who has single-sided deafness, it's a little bit different than our patients that have bilateral deafness, because now you have somebody who has a functional ear. So they're still able to be independent, but now we're focused on developing their binaural hearing or reintroducing that binaural hearing ability. So there's discussions of needing to wear it routinely. Can they change the batteries? Those sorts of things.
Yeah. Cognition is becoming an important issue in this population. Now, Dayse, down under, how do you assess that element in these elderly patients? Obviously, Frank Lynn's studies have shown, great impact, the potential benefit, or in dementia, impact on depression in these patients. So is it part of your standard assessment and counseling when?
Yeah, definitely. We have implemented using the high MoCA, so it's the MoCA for hearing impaired. We have implemented this now for a few years, and it's definitely part of not only for elderly per se, because we are doing this from 55 older and older, for all patients, regardless if it's single-sided deafness or bilateral deafness.
Mm-hmm. Rudolf, in Germany, do you have a different approach, or how do you use similar tools? Or?
Of course, it is important to have the family involved in the elder people. And of course, if you have an appointment with a patient, it is always advisable to have some family members with you. Otherwise, it makes no sense. And the time factor has also to be included, because it needs much more time in this population than in other situations.
You've been listening to Beyond Sound, conversations exploring the science, innovation, and human stories shaping the future of hearing restoration. Today's discussion highlighted that cochlear implantation in single-sided deafness is about far more than technology alone. From electrode selection and surgical strategy to counseling, cognition, rehabilitation, neuroplasticity, and long-term patient support, restoring binaural hearing is truly a multidisciplinary journey. A special thank you to our distinguished hearing experts, moderator, Professor Gunesh Rajan, then the panel, Professor Rudolf Hagen, Professor Dayse Tavora-Vieira, Professor Sima Sugarova, and Professor Meg Dillon. To continue learning from global leaders in hearing science and cochlear implantation, explore Hearing Boost, our educational platform from the Hearing Group, featuring expert lectures, roundtables, online courses, and clinical discussions from leading international specialists. Visit www.boost.hearing.com. Until next time, keep listening Beyond Sound.